कैसे होगी इसमें डाला होगा ना फिर लिंक पे डालना पड़ेगा।
Good evening, everyone. Most respected people who have already logged in, who are occupying the key posts in the American College of Physicians of India chapter. And I am really very happy to take part in this scientific meeting, which has been arranged by Dr. Anuj Maheshwari, who is the new governor of the American College of Physicians of India chapter. In fact, let me congratulate him for becoming the new governor of this prestigious association. And in fact, Dr. Muruganathan, who was holding this post, had now given to Dr. Anuj Maheshwari after the elections were over. And in fact, Dr. Anuj Maheshwari was kind enough to take the other people who were elected by the ACP people in India as the advisory board members to conduct all academic events under the banner of American College of Physicians, India. In fact, Indian Society of Hypertension, for which I am the president, we had a discussion with Dr. Anuj Maheshwari, and he was kind enough to say that we will have a combined meeting. And that is now materializing here this evening. And I'm really happy to have with us Dr. Flack, who is from United States. He is from the American College of Physicians, who has kindly accepted to be here as a first speaker. Of course, Dr. Anuj Maheshwari will be introducing him at a later stage. But my pleasure is to introduce Anuj Maheshwari to this audience. He is a good friend of mine. He is involved in various academic bodies. He is actually one of the pillars of Indian Society of Hypertension. Currently, he is a professor in the department of Lucknow University. And now he is elected governor for American College of Physicians of India chapter. And is also holding the post as the vice president of Research Society for the Study of Diabetes in India. Of course, he is involved in various projects and research work. And in fact, now if you just look at his bio data, it would take nearly about 10 minutes for me to read the entire thing. But suffice to say that we have a good friend of mine who is holding the current post as the governor of American College of Physicians of India chapter, and a great academician, enterprising person, and is friendly to everyone. With his probably involvement in this association as a governor, I am sure he will be in a position to protect the image of India through various academic activities. And with the help of all these people who had been elected as the advisory board members, Anuj Maheshwari will be in a position to show India to the entire world how active we are, how actively we are engaged in academic activities, in spite of the fact that we are encountering a great pandemic across the globe. With this introduction, let me now have the pleasure of congratulating Dr. Anuj Maheshwari and his entire team for becoming the key office bearers of the chapter in India. Over to Dr. Anuj Maheshwari.
Thank you, Dr. Narsingan, for the kind introduction and kind words for me. At this point of time, I may not forget the contribution of Dr. Muruganathan, who has really found me as a governor, as a successor of him, and truly speaking, becoming governor of American College of Physicians has never been in my agenda of life. It was Dr. Muruganathan who has really asked me and who has really inspired me to do all these things. He inspired me to take part in the election. And of course, I could be able to get this position because of the votes of American College of Physicians members. But definitely, the light has been enlightened by Dr. Muruganathan. Unfortunately, he is missing the event for some personal reasons. Of course, he has been the person who has introduced myself with Dr. John Flack, who is the speaker of today's event, and he will be the first speaker. Before I go for the scientific session, I will introduce briefly to my all other advisory board members who has been recently elected and they have taken the position of their office. So first of all, I shall like to introduce Dr. J.K. Sharma, who has been elected as the Vice President of the American College of the Physician. He is already having a post of the Regional Advisor of the Royal College of Physician, Edinburgh, North Central India. He is the Medical Director in the Central Delhi Diabetes Center, having the 33 years post-MD experience of teaching, practicing, treating the patients, and he is one of the very renowned physician of Delhi. Next to him, Dr. Narsingh Verma, who is the close associate of mine. He is the professor and head of Department of the Family Medicine as well as professor of the Physiology in the King George Medical University. He is already the Secretary General of the Indian Society of Hypertension. He is President of the Asia Pacific Society of Hypertension. And I am lucky enough to find him as a Secretary of the American College of Physicians this time. He has been elected on this post unopposed. Dr. Jalis Fatima, who is the Treasurer of American College of Physicians. She has been elected as a Treasurer of the American College of Physicians, presently holding the post of the Professor and Head General Medicine at Eras Lucknow Medical University. I think if the people, those who are here, they can show themselves and they can wave so that we can know that they are here. Dr. Banshi Sabu, who is representing the American College of the Physician as a West Zone representative. And I'm really feeling myself proud and lucky that Dr. Banshi Sabu, despite being the president of other prestigious organization like Research Society for the Study of Diabetes in India, he accepted to serve the American College of the Physician, and he is a well-known physician of the country as well as internationally famed person. He is director of the DIACARE Diabetes Endocrine Center at Ahmedabad. Then I would like to introduce Dr. L. Srinivas Murthy. Dr. L. Srinivas Murthy is the Senior Consultant Physician at Life Care Hospital and Research Center, Bangalore. He is Professor of the Medicine at Ambedkar Medical College, Bangalore. He is the clinical trial experience for more than 25 years. Dr. Swati Srivastav is the representing the Central Zone of ACP India chapter. She is the Professor of the Medicine, SMS Medical College, Jaipur. Dr. Anil Virmani, who is representing the Eastern Zone of ACP India chapter. He is a clinical cardiologist as well as he is holding the Vice President post of the Clinical Cardio-Diabetes Society of India. He is a faculty of the School of Diabetes in the Regional Yorkshire Research Foundation, and he is teaching and treating the patient for last more than 30 years. Apart from him, I am having with me the few of the very important people, those who have been given the post of those who have been representing one of the very important person who is representing the northern zone of ACP, Dr. R.R. Singh. Dr. R.R. Singh is the close associate of mine. He has worked together in many organizations. He has organized many conferences together. He is the director of the Raghavendra Hospital at Jhansi. Dr. Amit Gupta. Dr. Amit Gupta has been elected in ACP as a early career physician representative in ACP Advisory Council. He is already having the post of the advisory board member of the ADA. He is having the Diabetes Resource Centers Committee member of the American College of Endocrinology. He is running a center of the diabetes care of Greater Noida. Last but not the least, the person who is representing the women wing of the American College of the Physician, Dr. Divya Saxena. I am lucky enough to be in my team. She has been one of the very gracious senior in my MBBS days, and she has been accepted the proposal to work with me in the American College of the Physician. I really praise his contribution, his acceptance of contributing. She's already working on the various posts in the IMA, and she is very dedicated worker for the women's cause in various other organizations, and we shall be very happy once she will be an asset for the American College of the Physician. So with these introduction. I don't think anybody is left. If anybody is left, then he can ask me and I can introduce him also. But as far as my knowledge, I have not left anyone. Now I will hand over the session to Dr. J.K. Sharma, whom I have already introduced. Dr. J.K. Sharma to take the charge of the first session, in which Dr. John M. Flack shall be the speaker. Dr. J.K. Sharma.
Thank you, Dr. Anuj, and good evening to all and welcome to everybody on behalf of ACP India chapter. To start the scientific program of today's evening, the very first speaker we have is Dr. John Flack. Dr. John Flack is the Sergio Rabinovic Endowed Chair in Internal Medicine, Professor and Chair, Department of Medicine at the Southern Illinois University, United States. And in the next 30 minutes, we will listen to Dr. Flack implementing team-based care models to improve the hypertension control, which is a very, very important topic and talk for the today. So I invite and welcome Dr. John Flack to start his deliberation. Dr. Flack, please.
Okay. Well, good morning, all, and thank you very much for the invitation. I bring you greetings from the ACP Board of Regents here in the United States, and certainly we all wish you the best in dealing with the COVID-19 pandemic that we've all dealt with, but it seems like you're having a much harder time, at least in parts of your country. And please call on us if there's things that we can do to help. My talk today is really about how to improve hypertension control. And I believe that team-based strategies are an excellent way to do it. I am also president of the American Hypertension Specialist Certification Program. And as I mentioned, a member of the American College of Physicians Board of Regents. I'm the chair of the Department of Medicine, Southern Illinois. I have a couple of disclosures. One, I'm a consultant for Novartis, and two, I have grant and research support from GlaxoSmithKline, Bayer, Vascular Dynamics, Quantum Genomics, Recor Medical, Endorsia, and Vascular Dynamics. So the first thing I want to do is really take a bit of a swipe at evidence-based medicine guidelines. And I've certainly participated in these. I read them. I think at times, man, they're beautiful. But the problem is that evidence-based medicine guidelines are interpreted by experts around the world in various places, and they all come up with something different, essentially looking at the same data. So just as an example, and don't get caught up in the details, you have the American College of Physicians, American Academy of Family Practice, American Heart Association, American College of Cardiology, the European Society of Cardiology, European Society of Hypertension, and the American Society of Hypertension, which is no longer in existence. And look at the differences in the drug initiation blood pressure threshold and also the recommendations for combination therapy. The ACP AAFP for those 60 and older basically says start blood pressure meds if systolic's over 150, or if they've had stroke or TIA in the past 140 or higher. There's no recommendation on combination therapy. The AHA-ACC basically says 140 over 90 for most, 130 over 80 if high risk. And I think at times people misinterpret the guideline because you diagnose hypertension at 130 over 80, but only 31% of people initiate hypertension treatment before 140 over 90. Most still are 140 over 90. Now, this guideline basically says use combination therapy when your blood pressure is 20 over 10 above goal in most adults, especially Black. So it's a little bit wishy-washy in all, and most people focus on the greater than 20 over 10. But they actually did say for most patients, especially Black patients, which are harder to control. The European guidelines basically initiate blood pressure 140 over 90 for most and So you can consider it if you have cardiovascular disease, especially coronary disease, if you're a little bit lower than that. But their recommendation for initiating combination therapy is much more expansive and initiated in most hypertensives, except the frail elderly. And finally, the defunct American Society of Hypertension back in 2010, 2011 really initiate combination therapy in most hypertensive. Why? Because the vast majority of people who are going to get blood pressure control are going to require So this leads me to one of the most impressive and I think pertinent statements I've ever seen. And it came out of the Disease Month journal. And it said about evidence-based medicine, data aren't facts, facts aren't information, information is not truth, truth is not wisdom. The wise application of empirical facts to the care of the patient requires both information and judgment. And I think what our challenges are around the world is as we look at these guidelines, we need to take the best of any or all of the guidelines and tailor them and distill them into locally useful approaches that can support clinical decision-making and improve hypertension care. So optimal clinical decision-making really depends on accurate blood pressure measurement. And that's really a commitment to quality. And I will tell you that, yes, this is boring, but it's very important. Accurate blood pressure measurement at home or in the office is not going to occur by accident. Anyone in any setting measuring blood pressure accurately is going to have to be trained to do so. Here are 3 different approaches to measuring blood pressure. And here are the differences you get in blood pressure measurement. In the first one, the manual office, you just come in, sit down, somebody slaps a cup on you, no protocol used, no rest, and essentially your pressure is 155/90. If you take that same individual and put an ambulatory blood pressure monitor on them, their awake ambulatory blood pressure is significantly lower. If you put an automated office blood pressure machine on them that's validated with a cuff according to a protocol, it's essentially what you get with an awake ambulatory monitor, but it is substantially lower than what you get with what I call garbage blood pressures, where you just flip a cuff on and take it. So one of the key things about taking blood pressure inaccurately is most of the errors you make bias the readings upward. So there's 3 pillars of accurate blood pressure measurement. You need validated devices, you need the right measurement techniques, and you need the right measurement conditions. The American Heart Association and American Medical Association have come out with 7 steps that we actually have adopted in full in our clinic to measure blood pressure accurately. Have a quiet room, no conversations, no phones. Empty the bladder first. Use the correct cuff size. Place the cuff on a bare arm. The arm should not be hanging, but supported at the heart level. Keep the legs uncrossed and on the floor. Support your back and your feet. There is no way that you can do this and take blood pressure as quickly as you can when you are just popping the cuff on someone. But the reality is the blood pressures you get are going to be a lot more accurate and they're going to be systematically lower. So the lack of rigor in blood pressure measurement undermines hypertension care. You overdiagnose hypertension, you overprescribe blood pressure lowering medicines, you underestimate control rates in your clinic, and it contributes significantly to discordant clinic at home blood pressures, where you end up with white coat effect and or masked hypertension. So here's what happened to control rates over 4 quarters when we initiated a standard blood pressure measurement protocol in our general internal medicine clinic in Southern Illinois. And we did it around Q1 2017. Our control rates went up and peaked at about 64 or so from about 50% when we started this. And did our doctors get smarter? Well, I hope so, because some time elapsed. But the big thing is we measured blood pressure more accurately. This project won a practice-wide quality award for having a great effect on patient care. Now, multidisciplinary teams are really important to hypertension care, and there's evidence that supports their effectiveness in managing hypertension over and above just usual clinical care. So why don't we all embrace this? I can tell you in the United States, part of the reason we don't embrace it is because of the reimbursement system, the infrastructure that is required to execute this, and every place can't do it. The ACP actually came out a few years ago. Bob Doherty first authored a paper on the principles supporting dynamic clinical care teams and wrote a position paper on it. And essentially, it's a clinical care team for patients consists of health professionals. You can read the list there, who have the training and skills to give high quality coordinated care specific to patients' clinical needs. This is getting away from the old model of the practitioner and everybody serves a practitioner, but they're not really a coordinated team, to the practitioner. Yes, the needs of the practitioner are met, but also the needs of the patient, and that those individuals, the nurses, the pharmacists, work in tandem under the leadership of the physician leader. Now, one of the groups or types of people who can really help us in clinical care are dietitians. There are a lot of people with diabetes backgrounds on this call, and I can tell you, you all fully understand that. I don't think in hypertension we quite understand it as well as people in diabetes do. Dietary sodium intake is a major cause of drug therapy resistance, and even amongst patients who don't go to the dietitian, there's some simple office advice that you can offer to help them lower their intake. Now, there are other major lifestyle interventions that lower blood pressure, and I'll briefly cover those. In addition to sodium restriction, exercise, especially aerobic, but resistant isometric training and dynamic training also. Weight loss. Weight loss is hard, and the response of blood pressure to weight loss is variable, but there are a variety of health reasons that are benefited. And so if you can get weight loss, and even though we don't focus on it because it's hard to do, it's usually helpful. Limited alcohol intake. And the differences in recommendations for men and women are largely related on body size, and also increased intake of vegetable protein. Now, here's a study done years ago that still very impressive today. What happened was individuals with resistant hypertension were enrolled in a crossover trial, and they essentially went from 250 millimoles a day, which is about a little over 6 grams of sodium, down to 50 millimoles a day, which is 1 gram of sodium. They had resistant hypertension, and the solid circles and triangles represent when they were on the higher sodium, and the lighter colored circles and triangles represent after they were crossed over. And there's about a 23 millimeter of mercury systolic impact within a week or two, literally, of actually just cutting dietary sodium intake. That is greater than the vast majority of drugs that we use. There is randomized trial data of primary care-based pharmacist collaboratives with physicians managing hypertension. And this was done in an academic medical center on the West Coast. And their hypertensive patients randomized either to a pharmacist physician collaborative or a usual care in the general medicine clinic with general internists. The 2 clinical pharmacists and an internal medicine MD developed a collaborative practice protocol. And these patients in the collaborative were seen at baseline 3, 6, 9 months, independent of PCP visits, although they could have them, and they could get additional PRN clinics or phone calls. The visit durations were 30 minutes, and the pharmacist really adjusted the meds, discontinued meds, refilled drugs, etc. The mean difference in blood pressure at 6 months between the groups was fairly substantial. There was over an 8 millimeter of mercury difference between the pharmacy group, the collaborative group, and the usual care group, highly significant, that diminished at 9 months and had lost its significance. Diastolic pressure also fell significantly. Lipids did not change substantively. The control rates, though, at 6 months were outstanding. In the collaborative group, 81%. When you get 81% control, that is world-class hypertension control. What you see in the Kaiser system and the VA system in the US get in the high 70s, low 80s. Usual care was just a little more than half of that. So this group, this actually showed that you could actually do a pharmacy-led intervention, and it did better than just basically being in a primary care clinic. The pharmacy group had about 1.8 visits to their PCP, and the usual care group over that time frame had 4.2. Don't get too bogged down in this slide. It's just to summarize that there are a variety of interventions: self-monitoring, education by the physician, nurse, or pharmacist-led care, organizational interventions, appointment reminders, that actually have shown benefit in improving blood pressure responses in clinical care. So what's the responsibility on our team and at the hypertension clinic in SIU where I lead? Well, certainly as a physician, we conduct all the clinical visits, all aspects of diagnosis, evaluation, and care. In between visits, the patients call in, the nurse, MA, fields the calls. They may get bumped up to me or sometimes from the nurse practitioner, and we review labs and things, essentially what you do, I'm sure, as docs. Our nurse practitioner does mostly follow-up clinic visits for selected established patients that are super complicated, no. Patients who are new to the clinic, it's rare that she sees that patient before I do, or Dr. Adicola. Our nurse does a lot of the education on accurate home blood pressure measurements with our patients. We have a protocol for calibrating devices, reinforces medication changes at the conclusion of visits, and gives written instructions, and typically is first in line between in getting between office visit patient calls. I want to warn you though, and we have this problem in the States, be very careful about written instructions because some of our patients can't read very well. Our medical assistant does a lot of what the nurse does, does virtually all of our office blood pressure measurement with a validated device according to standard protocol, and is the point person for collecting home blood pressure measurements. And our dietitian provides dietary advice especially on low sodium intake. At the time of writing this slide, I did not have a pharmacist fully on board. And after preparing this talk and realizing that, my goodness, we've got a pharmacist right around the corner and we're not using her. She has been formally invited to join our team and is going to, I think, be a big help. Now, a lot of what's going to help blood pressure control is therapeutic decision-making. That's not the only thing, but it's important. And one of the big problems we have in the States is therapeutic inertia. That's seeing an elevated blood pressure and then doing nothing about it. Prescribing adequate intensity drug therapy with the right drugs is very problematic in the States. Avoiding poor or risky drug combinations and smart use of diuretics. So this is from a national survey. And notice where the bars are. For patients not on hypertension medication, they're around 30% and then lower over time. And for patients not on antihypertensive medication, so for patients on hypertension medication, you're actually around 10, 12%. And for patients not on antihypertensive medication, around 30%. Well, what is that 30% or 10%? This is the percent of office visits in a national survey where blood pressure was elevated and the drugs were titrated upwards. So what that's telling you is the vast majority of the time, particularly in those who are already on hypertension medication, that when physicians in the US see a patient, they don't titrate the drugs. And not only that, it has declined every year steadily since 2007, particularly in those who are already on antihypertensive medication. This is a very telling, sad slide, and it basically shows the proportion of US adults with uncontrolled blood pressure and the number of drugs they were taking across 3 time periods, with the most common single, double, triple, or 4 drug regimen underneath the number of medications they're taking. In the United States, it's been pretty steady since 2005, 2008. About 40% of adults with uncontrolled blood pressure only take a single drug. 35% take 2 drugs. That, by definition, is under treatment. Literally today, 75% of hypertensive patients in the US who are uncontrolled are undertreated by definition, not with enough drugs. The number of patients on 3 drugs has remained steady around 20%. And you can see that ACE or ARB plus beta blocker diuretic is the most common 3 medication class. 4 medications, 5 medications, a very small percentage. Common class of drugs, particularly in 2 and 3 drug realm, it's not so much the drugs are a problem. It's one, they probably aren't prescribed intensively enough, and 2, there's just not enough people on effective drug classes. So here's some characteristics associated with hypertension treatment intensification. Women are a little less likely than men to get titrated up. You're less likely the older you get, and you lose about 9% probability of being uptitrated for every decade of life older. The higher the systolic blood pressure, you are more likely to get treated, but still the number who get treated are low. Interestingly, if you're on more medication or existing hypertension medication use, you're less likely to get treated if your blood pressure is elevated than if you come in, you're not on meds and your pressure is elevated. So the real problem appears to be getting people up titrated once they're on meds. And then the more you see a patient, total number of visits within a year, the less likely you are when you see an elevated blood pressure to up titrate it. Chlorthalidone. When I have moved into various universities and start getting patient referrals for internally and externally, virtually no one's on chlorthalidone. And sometimes people ask me, what is chlorthalidone? What is chlorthalidone? It's a superior, much longer acting thiazide-like diuretic that has a bad rap for causing more hypokalemia, which it does, than HCTZ. It's been used in virtually all the risk reduction studies where we have hard endpoints, and it's superior blood pressure lowering drug. This is a crossover trial that was aborted because of a carryover effect. So we only are looking at the first part of the crossover trial. And this was in hypertensive patients where chlorthalidone 25 is compared to HCTZ 50 milligrams a day. And you see in the orange bars that 24-hour blood pressure was about 5 millimeters of mercury lower on chlorthalidone, and the nighttime blood pressure was substantially lower on chlorthalidone. And nighttime blood pressure is probably of the 24-hour cycle the most important blood pressure component for predicting cardiovascular risk. Now, the American Society of Hypertension back in 2011 or so made some really fine recommendations about combination therapy. And your preferred, most effective are going to be ACE or ARBs with a diuretic, or ACE or ARB with a calcium blocker. But there are other acceptable combinations of beta blocker diuretic, a calcium blocker, dihydropyridine and a beta blocker, an underused combination CCB diuretic, renin inhibitor diuretic, but renin inhibitors really have no market share here in the States. And really thiazide diuretics and potassium-sparing diuretics like hydrochlorothiazide or chlorthalidone or indapamide plus spironolactone and Clarinone or Muliride. When we wrote the first guidelines for treating hypertension in Blacks, and I chaired that group, we included a combination therapy table that had bad combinations, undesirable because they're ineffective or risky. ACE inhibitors and ARBs. There was a fascination in the States with using this. And quickly, when we studied it, it really was not a very good combination. Beta blocker and ACE inhibitor is great if you're going to have heart failure, but not so much for hypertension management. Beta blockers and non-hydropyridine calcium blockers like verapamil both have negative inotropic and chronotropic effects and should not be used together in most instances. Beta blockers and central inhibitors like clonidine, and alpha blockers and central adrenergic inhibitors. So what's a hypertension control checklist that I would suggest to you? One, you measure blood pressure accurately. Trained patients use validated devices in all settings, including your office. To the degree you can, implement lifestyle change. And what we try to do with our patients, if they won't go to the dietitian, or even if they do, is we tell them you can cut your sodium intake by doing two things. One, eat less. Leave 2 to 4 bites on your plate because sodium is highly correlated with the amount of food you eat and calorie intake. And two, cut down the high sodium food intakes by 25 to 50%. Breads, pizzas, soup, canned goods, processed meats like bacon, ham, salami, sausage, fast foods, pickles, pizza. Choose drug therapy wisely. Prioritize comorbidity indicated drugs. We didn't talk about that today, but for example, in patients who have had a history of atrial fibrillation, ARBs will reduce the recurrence of that. Post-MI patients, beta blockers, etc. And favor combination therapy over single drug therapy. It utilizes effective, safe combinations and avoid risky ones. To the degree you can, assemble a team to deliver care with coordinated roles that's led by your physicians. Pair action with patients. Avoid therapeutic inertia. And up-titrate your drugs about every 4 weeks. You don't need to titrate them in most instances quicker than that because it takes a while for long-acting drugs to actually increase their, implement their maximal effect. And finally, to the degree you can, move some of the clinical decision-making outside the office. If they're trained, know how to take their blood pressures at home and know how to report them, you can make clinical decisions on home BP readings. If the patient's not trained, you really can't. And empower your pharmacists and other health professionals to make protocol-guided, independent therapeutic decisions. So in summary, exemplary hypertension control is the outcome of the coordinated system of multidisciplinary care rooted in quality, patient activation, and high-level clinical decision-making. We have to translate the best aspects of divergent evidence-based guidelines into locally tailored clinical decision support that's imperative for high-level clinical decision-making and optimal hypertension control. And with that, I will stop. And again, it's my tremendous honor to have the chance to fellowship with you for a while this morning and to really at least give you my take on how we can work better to improve hypertension control. And I've written an editorial that's going to be published in Hypertension about this very subject, about a paper that's being published on blood pressure control in the US. So watch for that in the next few weeks or so online. Thank you.
Thank you, Professor Flack. Very wonderful, very informative talk delivered by you, where you have very well explained how important is the team approach, how we can look after the not only the diagnosis but also the management of hypertension when we involve the team and when there is a team approach. And the very important point which you have highlighted is where not to combine and which kind of medicine not to combine, and importantly the measurement part. So can we take the questions now or at the end? Dr. Narsingh Verma sir, Dr. Anuj.
I'm fine. Whatever
At
you
the
want
end,
to do.
at the end, sir. At the end.
One question which has come from Dr. Anil Virmani. Do you believe in de-escalation of the treatment? Now the point here comes is that good number of good percentage of patients are even not diagnosed who are hypertensive. They even do not know that they are hypertensive. So once they are diagnosed, they are under control, then we can think of our comment, your comment, Dr. Flack, regarding this.
Yeah, we de-escalate treatment solely on the basis of, is their pressure too low, or do we think that something has changed, that they get dehydrated, sick, lose weight, and now we got them on too much medicine. But if I have someone in our clinic who is 115 over 68, they're doing fine, am I going to start de-escalating their medicine? No. 115 in our clinic probably correlates to about 125 to 130 in many other clinics because of the way we measure pressure. So patients will do that on their own, and the natural experiment on that is when they start de-escalating their medicines, sooner or later their pressure goes up. One thing you will find is that when you withdraw diuretics, for some reason we don't know why, but the blood pressure will come up slowly, the slowest after withdrawal of diuretics compared to any other drug class. So as a routine practice, no, unless we think the patient is got pressure that's too low, they're symptomatic, become orthostatic or something like that.
Thank you. Thank you very much.
So, Dr. Flack, will you be able to stay with us in the end for the question answer session?
Yes, yes. And also, too, I will send you all my slides. I tried to send them. We're down at our lake house in Oklahoma, and I don't have enough bandwidth to get the file. It won't upload the file. I'll try again after the session, but I may have to wait until tomorrow when I get back to the office. But I'll send you my slides.
Thank you.
Thank you. Thank you, Dr. Flack. Now we shall be proceeding towards another session, which shall be taken by Dr. Narsingh Verma. Dr. Narsingh Verma, as I already introduced, he is a professor and head of department of the family medicine in KGMU, as well as he's professor of the physiology. And he is the president of the Asia Pacific Society of the Hypertension. He is the Secretary General of the Indian Society of Hypertension. So with these words, I shall be requesting Dr. Narsingh Verma to take their deliberation, which is on adolescent hypertension. And this is very important topic for the Indian hypertensive population, because we Indians are 72% less than 40 years of the age. So this is really very much needed and important for Indian population. Over to Dr. Narsingh Verma.
Thank you, Professor Maheshwari, and for giving me this chance to talk about adolescent hypertension. At present, my group is also working in this particular field. So I will like to talk something about the adolescent hypertension. I will share my slides, and whether my slide share, where is gone? Where is it gone? Whether my slides are visible?
No, sir.
No. So what to do?
So just open the presentation once on your system.
Already open. It is already open.
Okay. Now click on the share button, upward arrow.
I know that. I have already shared it. I have shared the screen, and in that particular screen, share button, I have already shared.
Yeah. Yes.
Now I think my slides are visible.
Yeah. Just put it in full screen mode.
Yes, sir. Slides are visible?
Yes, sir.
Okay, thank you.
They are
So,
visible, yeah.
fine. So I will be talking about adolescent hypertension, and particularly in India. As mentioned by Dr. Anuj, that adolescent hypertension is a very important aspect, and we all know that hypertension in children is a growing epidemic all over the world. And the basic important fact is that still it is not being noticed. High blood pressure is estimated to be prevalent around 4.5% of the children, but it is very highly variable. Some part of the country reports it is very less prevalent. Other part of the world report that it is highly prevalent. And this is happening just because the data are so variable, because the data are less and it has not been measured in most of the time. So the first report on the pediatric hypertension by National Heart, Lung and Blood Institute, published in 1977, they declared that detection and management of hypertension in children and precursors of hypertension in adults are the next major frontier. But the report also recommended annual BP measurement in all children more than 3 years, but nothing happened. Unfortunately, nearly 40 years later, the diagnosis of hypertension is missed in the majority of cases, and familiarity with pediatric hypertension among clinicians is extremely poor. That is why our group is trying to create awareness about pediatric hypertension, adolescent hypertension, because it is a problem which will ultimately convert into adult hypertension as well. So the risk factors for the adolescent hypertension are almost same, but if we know that every 20 millimeter mercury increase in systolic blood pressure or 10 millimeter mercury increase in diastolic blood pressure increases mortality from heart disease and stroke in adult. It doubles, but in risk factor for adolescent hypertension, if we go, they are mainly overweight and obesity. The prevalence of hypertension is much higher among overweight and obese children, with estimates of 4% to 14% and 11% to 23%. Other risk factors apart from obesity are abdominal obesity, waist circumference, and additional risk factor include dietary salt intake, especially in the adolescent age group, which are very fancy in eating outside and consuming a lot of material which has high salt, and other factors responsible for development of hypertension. So causes again are the primary and secondary. Primary causes are again more in comparison to secondary, but if you compare, the secondary causes of hypertension are more in adolescent age group in comparison to adulthood, but primary cause is still common than the secondary causes. Characteristics of children with primary hypertension include older age, positive family history, and overweight and obesity. Diastolic blood pressure elevation appears to be more predictive of secondary hypertension, whereas systolic is more predictive of the primary hypertension. So secondary causes, if we go, they are almost same: renal and the renovascular, cardiac, including aortic coarctation of aorta. This had to be diagnosed very early, and endocrine causes of hypertension. Environmental exposure, most prominent are lead. And this is very, very important because most of the in part of the India is still the lead industry has a lot of child labor, and these children are exposed to lead, and our group have found that they have high hypertension. Neurofibromatosis can again be one factor which can lead to hypertension. Medication related, common medication associated with rise in BP are the central nervous system stimulants and corticosteroids. Prevalence, again, I will say, is very, very variable. Data are also very inappropriate, has not been given due importance. Most accepted is 4.5% in USA. Other part of the world do not have the anonymous data. But everyone says that it is increasing worldwide. Prevalence in India, a very good study published in 2020 in PLAS One that has taken account 25 studies, and the pooled sample is very high, 27,682 participants, and the prevalence of hypertension across studies ranges from 2% to 20%, again highly variable, and the pool estimate is 7.6%. So you can say that pool estimate at present in my country, recently in 2020, we can say it is 7.6%. That is what we have according to our data. Some studies done at Delhi, the Nazafgarh study, that has shown that the sample size was very less, that has shown 7% again. Another study done in the school children's, and this shows that 7%, around 7%, again showing the same prevalence. Another study in Chennai, Tamil Nadu, that has shown that the prevalence of adolescent hypertension was 21%. That was the only study with a very high prevalence, especially in Chennai, Tamil Nadu. And the major determinants were found to be increased body mass index and decreased physical activity. Not only in India, neighboring country like Iran, again, the study have revealed that the prevalence is very high. Our lab has done study, if the corona had not come, we have reached to around 20,000 children, but because of the corona, we have limited ourselves to 25 schools in North India, especially from Lucknow. And the pro forma was made, detailed medical history was filled with 800 students of age group of 11 to 17 years. And a cross-sectional study was conducted in 25 schools around Lucknow, Uttar Pradesh. And the anthropometric data were collected. Heart rate and blood pressure, systolic, diastolic was taken thrice each in left and right arm with Omron blood pressure monitor, and average was noted. If we go by the demographic profile, anthropometric measurement, clinical examination, all were collected, results show that around 11.5% were found to have predominant systolic hypertension, while 3.62% were having the diastolic hypertension. So systolic one was found more, and overall prevalence of hypertension was 15%, well above the national average, which has come from the other studies. We were able to find out. And the important thing here is that these all schools were not having the children, all of them were not obese or overweight, and still the hypertension was there. And what we can presume, we can hypothesize, we don't have any parameter which has been studied, but the main reason was the stress and the food they are taking out of the home. So we were able to conclude that adolescent hypertension is now not rare in developing countries, including India, and this can be attributed to social factors, dietary habits, lack of physical activity, and more importantly, rising stress level in adolescents. That's what our lab study shows. If we go around the world, how we can classify adolescent hypertension 1 to 12 years percentile base, up to 12 where it is percentile base. 90th percentile normotensive, if they are less than 90th percentile, 120/80. Elevated blood pressure when more than 90th percentile or more than 120/80. So it is the percentile based. By that we can find out whether the children is having hypertension or not. But all patients more than 13-year-old, the static threshold of normal blood pressure is 120/80, elevated blood pressure 130/80, hypertension 140/90 from the bound regardless of teenage, height, or gender. The adoption of uniform definition for blood pressure classification in teens and adults will greatly facilitate transition of care from pediatric-centered practice to internal medicine or adult-oriented care. That was the very important study published in American College Cardiology in 2017 that stated that more than 13 years you have to take like this. And diagnosis again was the chronic childhood hypertension is made when the auscultated BP values on 3 repeated and separate visits are greater than 95th percentile for the age, sex, and height of the patient, or more than 138. So how we work up these cases to rule out renal causes, other causes of secondary hypertension had to be ruled out. Regional epidemiology will also be considered. That is most important. And the fourth report suggested immediate echocardiogram at diagnosis. That helps us to find out the cardiac causes as well. New lower treatment targets were done at 2017. ARP-CPG recommends new lower treatment targets for those without additional risk factor. Treatment should target BP less than 90th percentile, given recent evidence that target organ damage may appear at BP value below the 95th percentile. So we have to go little lower to prevent the target organ damage. Treatment goals, definitely they will be decided on the basis of the 90th percentile, which I said in the beginning. And the most important drugs, it was emphasized that before drug, we have to emphasize more on lifestyle modification, including dietary changes and increased physical activity. It remains the cornerstone of initial treatment and should be attempted for at least 6 months before going for any drug. If these modalities fail to control blood pressure, first-line pharmacological agent to control blood pressure in children and adolescents have been clarified to include RAS blockers such as angiotensin-converting enzyme inhibitors or angiotensin receptor blockers. Long-acting calcium channel blockers have also been used along with thyroid diuretics. So it remains almost similar to adults. One question remains that whether tracking of BP has any role. Measurement of BP in children have not been consistent. Lack of strong data is one reason. So prevalence is not very less. We have to think over that. Tracking definitely help us. So that is why it is important. It is a strong indicator. Childhood blood pressure is a strong indicator of adult blood pressure. Hence, early intervention is important. That can prevent the development of the adolescent hypertension into the adult hypertension. So we can say that the outcomes, if we go for that, then we have to find out that basically we have to go for the checking of blood pressure, and then we can find out whether the patient, by 2D echocardiography, whether patient is having left ventricular hypertrophy, and we can find early LVH, and then we can our intervention can be more beneficial if we can diagnose them early. The other associates were obesity, insulin-dependent diabetes, dyslipidemia, chronic renal failure, and these all are important. That is why we have to keep an eye all over that. Microalbuminuria is another important factor we have to keep in mind in our adolescent hypertension individuals along with the left ventricular hypertrophy. So recommendations are to improve clinical practice, and they are the low rate of recognition is important. So we have to be more intensive. We have to do the blood pressure in the children as well, and the clinical decision and support and the treatment in the form of the lifestyle intervention had to be recommended. ABPM again, ABPM, what is the status of ABPM in children's and the adolescent hypertension? Definitely the ABPM should be used in all children with clinic BP values, because that will be able to diagnose them very precisely. So ABPM has a role in the adolescent hypertension. These are the clinical practice guidelines for screening and management of high blood pressure in children and adolescents. They are almost similar, but we have to be more careful, more monitoring of blood pressure is required, and more emphasis on the lifestyle intervention rather than jumping onto the drug. Screening is more important, and diagnosis is important. Measurement of blood pressure is important, how we are measuring it, and we have to rule out the even white coat hypertension and mask hypertension by the help of home monitoring or the ABPM. So ABPM has its role. We can find out by using ABPM, we can intervene early when even the target organ damage can be prevented. So ABPM should be done, preferably using a standard approach interpreted with predictive normative data, and early use of ABPM can diagnose most of the children. So I can conclude that the adolescent hypertension is increasing all over the world. Still a lot of cases are not being diagnosed, and new recommendations of ARC-CPG are helpful in diagnosis and management of adolescent hypertension. We should go to these ARC-CPG guidelines. They are very, very helpful. Recommendations are very helpful, and measurement of blood pressure in this age group have its own intricacies, and they have to be looked after. So thank you very much. With both primary and secondary hypertension are common. So we have to go for the renal causes and to try to find out the other causes, including the coarctation of aorta, which is have to be more emphasized, because if we can diagnose it early, we can prevent a lot of complications. Obesity, social factor, and stress are important causative factors. The left ventricular hypertrophy, intima media thickness, and microalbuminuria are powerful predictor. We have to rely on them. So thank you very much for giving me this time to interact about adolescent hypertension.
Thank you, Dr. Narsingh Verma, for the nice deliberation, and especially it is creditable that you did this in very small span of the time, very short notice. You presented a very nice deliberation. So really thankful from the bottom of my heart and from the ACP. And really we wish the people like that should be in the ACP governing council, so that we may not have any interruption in our program anytime. With these words, I would like to little summarize this talk that Dr. Narsingh Verma has emphasized on the monitoring of hypertension, especially in the adolescent age. Most of the time in adolescent age, hypertension is not simply because of some important underlying reason. Sometimes it may be because of the sympathetic overdrive. Sometimes it may be because of the metabolic tendencies like obesity, like insulin resistance, which is increasing in the adolescents and children. That may be one of the important reasons of hypertension. So, of course, with the secondary hypertension, we must not forget all these things which may remain there behind the hypertension. We shall be coming up with a few questions at the end of the session, in question answer session. Before that, I shall be handing over the session to our next chairperson, Dr. Anil Virmani. Dr. Anil Virmani, I have already introduced. He is a very senior physician of Jamshedpur, Jharkhand, and he is one of the important representative of Eastern Zone of the American College of Physicians. And this is one of the great honor that Dr. Virmani is with us as the chairperson. Over to Dr. Virmani.
Thank you, sir. At the outset, congratulations, Professor Dr. Anuj Maheshwari, for taking over as the governor of ACP India chapter. After listening to two excellent talks, we have none other than our stalwart, Dr. Sanjeevi Narsinghan, who is the national president of the Indian Society of Hypertension. He is a board member of World Hypertension League. He is vice chairman of the Lipid Association of India. He is an excellent orator, and above all, he is a very humble human being. Over to you, sir. He'll be talking on guidelines in hypertension, whether there is confusion or there is clarity. And I'm sure he's going to reply back to Dr. John Clark, who talked about the caveats of evidence-based medicine. Over to you, sir.
Thank you. My slides are visible.
Yes, sir. Yes, sir.
Am I audible? Yeah.
Yes, you are audible.
Good evening, everyone. Thank you very much, sir, Dr. Anil, for the nice introduction. Let me now try to talk to you something about the guidelines in the management of hypertension. We know very well that there are a number of guidelines available across the globe, whether they really created confusion or is there any clarity. Let me now try to go on describing each and every guideline. But I would like to concentrate mainly on three important guidelines, which is one is 2017 ACC/AHA guidelines, 2018 European Society of Cardiology and European Society of Hypertension guidelines. The third one, or last year it was published, International Society of Hypertension guidelines. When you go through these guidelines, let me also try to tell you what is the evidence available with us, which can probably be embracing about the recommendations given by the various guidelines. What are the similarities between these guidelines and what are the differences? How best we can probably implement these guidelines in our clinical practice. Hypertension is the most common condition seen in primary care. It leads to myocardial infarction, stroke, and renal failure. Atrial fibrillation, peripheral artery disease, and aortic dissections are not uncommon complications. We should not forget about the dementia, which is a common complication of untreated hypertension. Death occurs if adequately not treated and if it is not diagnosed also properly. There are emerging trends in the hypertension epidemiology. Globally, it is seen about 26% of the world's population. Approximately 972 million people suffer from hypertension. And if you rely on this particular number of 26%, it is possible that we can encounter about 29% of the population by 2025 to have hypertension. What is the Indian prevalence? The study revealed that hypertension is commonly seen in our country to the extent of 29.8%. It is no longer considered as an urban population problem. It is also seen even in rural India. 33% of urban population and 25% of rural population are affected by hypertension. People who are taking treatment for blood pressure, whether they are all coming under control, the data tells you that 1/10 of the rural and 1/5 of urban population seem to be probably having a control of blood pressure when they have an adequate therapy. Let me now try to talk to you something about the 2017 ACC/AHA guidelines. We need to remember that about 11 organizations who had probably contributed information for the guideline developers to come out with the 2017 guidelines, which is promoted by ACC as well as AHA. If you look at this particular projection, you will be surprised to see that the systolic blood pressure goal to treat hypertension was coming down gradually. In JNC 4 and 5, stressed that it should be around 160. Later, JNC 6 came down to the levels of 150. 140 was maintained for many years, and it was approved by JNC 7. In fact, we all witnessed the publication of SPRINT trial in the year 2015, which had brought down the levels of systolic blood pressure by 120. And if you are able to bring down the levels to 120 in aggressive management, it is possible to reduce the cardiovascular risk as well as mortality. And that study probably had influenced the ACC/AHA guideline developers to bring down the systolic blood pressure goal as 130. In fact, if you look at the data that is available with us with regard to the SPRINT data, we need to remember whatever has been identified as 120 by the SPRINT trial is equal to 136 to 140 of the blood pressure detected in the clinic. The same thing is true even for diastolic blood pressure. What was detected as was 76 in SPRINT trial is equal to 82 or 84 of diastolic blood pressure in the clinic. Having seen this, let me now try to tell you the first projection from the ACC/AHA guideline, which actually invited a lot of criticism when people brought down the levels of the systolic blood pressure as the one which has to be probably kept as a threshold for making a diagnosis of hypertension. The normal is 120/80. The elevated blood pressure is 120 to 129, keeping the levels of diastolic pressure around 80. Hypertension stage 1 is 130 to 139, 80 to 89. I would request you to concentrate on these two. One is an elevated blood pressure, the other one is a stage 1. What was previously practiced by all of us with the introduction of the so-called terminology that is pre-hypertension, 120 to 139 systolic and 80 to 89 diastolic was considered as the pre-hypertension range, which was introduced by JNC 7th, which has been divided by the ACC/AHA guidelines 2017 as elevated blood pressure 120 to 129 and hypertension stage 1 as 130 to 139. The stage 2 hypertension is 140 and above and 90 and above diastolic blood pressure. Having seen this, let me now try to take you to some examples of the investigations which had been conducted in the past, which was published in JAMA 2005. The Framingham Heart Study actually concentrated on participants above the age of 80 years, and they were surprised to see that the pre-hypertension, the cardiovascular events which are very high in pre-hypertension group compared to normal blood pressure group, 9.5% of CV events occur in normal individuals. Those people who had pre-hypertension above the age of 80 years had nearly about double the number what we are seeing in normal, that is about 9.5 and comes to about 19.8%. So that shows people above the age of 80 years also, when they have pre-hypertension, they are at a very high risk of developing a cardiovascular risk. Having seen this, the pre-hypertension, the terminology that was used in those years, now the terminology has been removed. We need to remember 120 to 139 systolic and 80 to 89 diastolic is considered as a pre-hypertension. Compared to normal individuals, people who had pre-hypertension had higher cardiovascular events. And of course, people with the diabetes also had higher cardiovascular events. What is important is to stress the role played by the pre-hypertension along with the diabetes to push these patients for increasing cardiovascular events. Having seen this, let me also try to tell you that there is a good data which got published in DASH, 2,584 adults, and they were all followed up for a period of 7.7 years. An editorial was also written on this particular article, where you can see that people who were having blood pressure of less than 140/90 had 63% events when compared to people who had more than 140/90. Again, stressing the importance that we need to bring down the levels of systolic blood pressure, as has been done by the ACC/AHA. Having seen this, this is the data which is from India. We always require data, from our own country. There's an excellent data called Mumbai Heart Study. This study actually evaluated nearly about 148,000 patients, followed up for a period of 70 months, and they are actually identifying the people who died due to ischemic heart disease. You can just appreciate that people who had the so-called pre-hypertension range ranging from 120 to 129 had an hazard ratio of 1.16, and when the levels were going beyond 130 to 139, the hazard ratio for dying due to ischemic heart disease come under the category of pre-hypertension, where the involvement of the ischemic heart disease in this group. The same thing is true when people develop a cerebrovascular accident and they're dying. In the same Mumbai Heart Study, which had clearly revealed that the hazard ratio for 120 to 129 from 1.16 hazard ratio jumps to 1.73, indicating that the risk of dying due to cerebrovascular accident is higher in patients in whom the pre-hypertension is the predominant problem. There is also yet another data which got published in JHS in the year 2017 by Dr. Venkatesh Ram. This is actually in a semi-urban or a semi-rural area, Aragonda, which in Chittoor district of India, where he has evaluated nearly about 16,000 patients about the age of 15 years. They had encountered people with a pre-hypertension. The prevalence is high. Nearly about 39% of the patients were having pre-hypertension. The range is from 120 to 139. Again, stressing the importance of identifying people in the pre-hypertension group, which we know that they will also develop hypertension in the due course. Nearly 50% of them will develop hypertension. The most important message comes from this particular meta-analysis that the hazard ratio for all pre-hypertension group, whether it is 120 to 129 or 130 to 139, the hazard ratio for cardiovascular mortality is high, the stroke events are high, the coronary heart disease is 1.33, and myocardial infarction 1.99. What is important is to appreciate the stroke events hazard ratio is 1.95, and for myocardial infarction is 1.99 in the pre-hypertension group in this huge meta-analysis, which again stress the importance of identifying people even at this lower level of blood pressure. Let me now try to take you to the levels of understanding of BP goal. In fact, in 1990s, we were all practicing that 140/90 was considered to be the goal of threshold for blood pressure diagnosis, and bringing it down to the levels of less than 140/90 was a one appropriate treatment has to be instituted to bring down the levels to 140/90. What is the influential study that had probably be considered as a very important study is that the STEP study, systolic hypertension in the elderly program. People above the age of 60 and older were recruited for the study. The death also came down to 13%. Indicates that chlorthalidone, a diuretic, is a wonderful drug, which can also be used in people who are elderly, above the age of 60 years. There's a huge amount of benefit that was seen in this oldest study, that STEP study. Now, recently people had published this data in 2011 in JAMA, which indicated the long-term follow-up of the STEP study, which indicated that 22 years of follow-up of all those patients were recruited for the study. There was a, particularly for the CV and the all-cause mortality and the extended life expectancy. Surprising to see that people on active therapy lived on an average 516 days longer and 205 days free of all-cause mortality, not necessarily CV mortality. Again, indicating that diuretic, particularly chlorthalidone, probably will be the better choice of diuretic, even in elderly people. And a long-term follow-up had definitely shown a lot of benefits for these people to live for a longer period. Having seen this, let me now try to concentrate on the one important landmark study in the field of hypertension, that is ACCOMPLISH study, which had shown the more the reduction that is seen right from 140 systolic blood pressure, you reach the levels of 140, less than 140 and above 130, you get a reduction in the primary endpoints. If you reach the levels of less than 130, and up to 120, you get more amount of benefit. Whereas when you go beyond 120 and less than 120, you have an increase in the cardiovascular events, the primary endpoint goes up. So that by indicating the Jacob hypothesis is probably operating. We need to remember even the cardiovascular death also actually comes down remarkably when the blood pressure systolic comes down to the levels less than 130 and above 120 compared to 140 and above or 130 and above. I think this is a very valid trial which had indicated that the systolic blood pressure should be around 130. If you are able to bring down the blood pressure after starting the treatment, and if you're able to control the blood pressure within a period of 6 months, in this particular study, value has shown the beneficial effects in stroke events, cardiac events, all-cause death, myocardial infarction, heart failure. The message is very clear. If you are able to bring down the blood pressure and reach the goal as early as possible, within a matter of 6 months, as per the projections made in this value trial, we can get the benefits in almost all cardiovascular outcomes. So having seen this, let me now try to take you to the levels of our understanding with respect to the control of blood pressure and the benefits what we see through this meta-analysis. I'm now making it simple for you because instead of going through the small letters, I thought we can simplify it. The number of studies which were taken into consideration for this meta-analysis 123, more than 614,000 patients were recruited for all these studies. Every 10 millimeter reduction in the systolic blood pressure resulted in the CVD events risk reduction about 20%, CHD by 17%, stroke events came down by 27%, heart failure came down by 28%. What is important is even all-cause mortality came down by 13%, thereby stressing the importance of controlling the blood pressure. In fact, if you analyze all the data, the benefits were seen in all people when the blood pressure systolic was brought down to the levels of less than 130. The people who were benefited particularly with the blood pressure lowering is individuals with a history of cardiovascular disease, coronary artery disease, people with diabetes, people who had already developed stroke, heart failure, and CKD. Having seen this, this is a very important message. Aggressive treatment compared to the less intensive treatment, if you are able to see the benefits, that is going to be probably useful for our practice. For example, this meta-analysis which had concentrated on those people who received aggressive treatment compared to people less intensive treatment. The benefits are seen in almost all parameters. All the things are seen only on the left side, indicating there is a benefit to stroke, coronary artery disease, stroke plus CHD plus heart failure, which indicates aggressive treatment of controlling blood pressure to the goals level probably will make these patients comfortable. Having seen this, this is another data. People above the age of 75, they do get benefit when they are given an aggressive management of blood pressure. Look at the data. The primary outcome, actually, people who received the intensive treatment above the age of 75 had shown benefit when compared to people who received only the standard treatment, nearly about 34% risk reduction. Even the all-cause mortality came down by 30%, surprising. So people above the age of 75 years, even if they're given an aggressive management of blood pressure, you do get benefit even in all-cause mortality to the extent of 33%, indicating that we should control the blood pressure even in elderly people. This is a meta-analysis, nearly about 61 prospective studies, observational studies included here, 1 million adults. The message is very clear. If you are able to bring down the systolic blood pressure by only 2 millimeters, it is possible to get a reduction of ischemic heart disease mortality by 7%. The stroke mortality comes down by about 10%. What a beautiful information that we are now getting it from this meta-analysis, thereby stressing the role of the BP lowering drugs, the importance of lowering it, the importance of reducing it by millimeter by millimeter. I think every millimeter reduction of systolic blood pressure definitely counts in the reduction of the cardiovascular benefit. The ACC/AHA 2017 normally does not recommend combination drugs. Any one of the drugs can be chosen. Diuretics, yes, good. ACI, ARBs, and CCBs. In fact, the beta blockers are listed as the secondary agents and not primary. In fact, among the primary agents, the diuretics are stressed very much. Chlorthalidone was preferred on the basis of prolonged life and proven trial reduction of cardiovascular disease. What about the BP and the cardiovascular risk? I think we need to remember that there are a number of chronic conditions which seem to be associated with hypertension, like obesity, metabolic syndrome, diabetes, lipid disorders, and hyperuricemia. We need to concentrate on all those parameters to have the maximum benefit of risk, only risk reduction, even the mortality reduction. The strong blood pressure, as has been projected, this is a wonderful slide which had come out from ACC/AHA. The threshold for making the diagnosis of hypertension in patients in whom you have more than 10% of risk, 130/80. If it is less than 10%, probably 140/90. Other than that, almost all people in the general or in the specific comorbidity, whether diabetes, CKD, or heart failure, or stable ischemic heart disease, the secondary stroke prevention, 140/90. The rest of them probably will be coming under the label that we need to keep the threshold as 130/80 to make the diagnosis of hypertension. The goal of blood pressure to reach in all these categories of patient is 130/80. Very simple to remember. Very simple to remember. Your goal should be 130/80 in most of these. I'm not talking about all cases, in most of the cases. Having seen this again, I'm now trying to project this particular picture showing that 130 systolic blood pressure, which has been brought down by the ACC/AHA, fully justified. Having seen this, let me now try to take you 2021 also. It was again re-emphasized and was the same classification is maintained, the same recommendations are maintained. Here, the optimal blood pressure 120/80. The normal is 120 to 129. High normal is 130 to 139. Again, I'm trying to tell you that the pre-hypertension is divided into two categories. 120 to 139 is pre-hypertension. It is divided into two categories. One is normal, the other one is high normal. After the grade 3, very difficult to remember all these numbers unless you have. Between the ESH and ACC/AHA guidelines, the ESH guidelines, the threshold is 140/90. ACC/AHA threshold is 130/80. The BP targets for treatment is 140/90 if the treatment is well tolerated, otherwise 130/80, but never go below 120/70. Whereas ACC/AHA tells you there's 130/80 for almost all categories. Less than 65, ESH tells you that you should keep it at 130. Above 165 years of age, almost the same. And the risk score that has been used for identifying people who have atherosclerotic cardiovascular risk by ESH guidelines is a score, and the ACC used the ACC/AHA pooled cohort score. The ESH guidelines actually gave importance to the hyperuricemia as one important cardiovascular risk factor in association with hypertension. Elevated heart rate, which is very important for Indians, because most of the Indians, and as per the India Heart Study also, there seems to be an increase in the heart rate more than 80 in Indians, which probably get them pushed for early development of damage to the vessels, and then probably increased sympathetic drive is known to get problems of incident hypertension and cardiovascular complications. In fact, the ACC/AHA do not recognize them due to the limited evidence that the treatment improves the clinical outcomes. No. Whereas the recommended combination here, RAS blocker can be combined with an SCCB or a thiazide diuretic, but no specific drug combination recommended by ACC/AHA guidelines. Now, having seen this, I should talk to you about the combination therapy that has been recommended by European Society of Cardiology, and again stressed even this year also 2021 ESC and ESH guidelines. You choose either ACA or ARB, combine it with a CCB or a diuretic, any one. So two combination, preferably a single pill. If the fellows are not responding, probably you should choose a diuretic at that stage. or a CCB, whichever is the first one that is chosen, you can go to the second one. Go for ACA or ARB, one drug, CCB plus diuretic. So all three drugs, and that should be the second step. Again, it should be in the form of a single pill. Now, the resistant hypertension, if it is not responding, you call it as a resistant hypertension. The definition I don't want to dwell here because of the lack of time. Probably you need to understand that we need to add a drug called spironolactone in those individuals who do not show a response. Of course, you require a two-pill combination here. Let me now try to take you to the last leg of my talk, that is International Society of Hypertension Guidelines, which was published last year. In fact, they are not recommending anything new apart from the thing what we had seen in 2018 and 2017 guidelines. They had also taken into consideration the NICE guidelines. They had also taken into consideration the Japanese guidelines. In fact, they had only modified certain things. They considered that normal blood pressure is less than 130, systolic and diastolic is 85. Probably based on the main measurement blood pressure readings, which they had obtained from various countries across the globe. These levels probably were identified as normal. Of course, I don't want to dwell here how these people had graded it. Let me try to tell you what is important is about the drug sequencing. Though the ESA guidelines and ESH guidelines are also given the information about the combination of drugs, where ACA or ARB plus CCB or a diuretic, here they have simplified it. They wanted to give for two groups. One is essential, the other one is optimal. People who are coming from the lower middle income countries, they need essential way of approach of treatment for high blood pressure. Whereas an optimal care should be given for people who are coming from high income countries. So we need to remember that the same one, but diuretic is not given importance here by ISH. A plus C should be the first choice. Start with the low dose, dual drug, single combination. After some time, increase the dose, go for the full dose, the same drugs. Fellows are not responding, go for the step 3, triple combination, A plus C plus D. People are not responding, think about resistant hypertension, use spironolactone, depending on the eGFR, depending on the potassium levels. This is the recommendation given by ISH guidelines, which seems to be a very simple recommendation. Of course, for people who are coming from lower middle income countries, all that you should do is to use whatever drug is available to reduce the blood pressure. Use a free combination instead of a single pill combination. Use thiazide diuretic instead of a thiazide-like diuretic like chlorthalidone or indapamide. Use any calcium channel blocker. If you don't get amlodipine or any newer calcium channel blocker, probably you can choose even the non-dihydropyridine group of drugs like diltiazem or verapamil. For essential and optimal, there is also a role for beta blocker. Of course, it is just the same as has been recommended by all these two academic bodies. Beta blockers probably should be chosen at any stage also, provided the patient has a concomitant problem like angina, increased sympathetic drive, arrhythmia, heart failure. If somebody is seen with that first stage itself, you need to put them on a beta blocker. Otherwise, as an antihypertensive drug, probably that should be chosen as a last resort in the management of only hypertension. Again, I'm trying to show the same slide, which gives you an impression now. What was projected as 130 by ACCHA in the year 2017 as a goal for most of the patients. Almost most of the things that have been recommended for various categories of hypertension, various categories of patients as a goal by ESC and ESH is also 130. And ISH also tells you that you should keep the levels around 130 or less than 130. So whatever is their definition, though there is diverse in their opinion with regard to the threshold for making the diagnosis of hypertension, they converge to the particular goal of 130/90 for most of the patients. That's the message what I thought I should share. So ladies and gentlemen, having listened to my talk, the very simple way of understanding is that you can choose ACA or ARB, but the better one will be ARB, because studies have shown that the compliance is excellent, adherence is important, very important, adherence is excellent with the ARBs, and ARBs least side effects, cough is less, angioneuritic edema is less. So ARB is the one which can be chosen, which is being practiced in our country. Of course, the next combination is CCB, which is recommended by ISH. Diuretic is also yet another choice which need to be considered as the combination drugs. But what is important as an optimal combination therapy, as has been recommended by ISH, ARB plus CCB, ACA or ARB plus CCB. But for our country, I can say that ARB plus CCB will be the ideal combination. So, in summary, how to implement it in clinical practice. Having listened to this particular lecture, you may be wondering how we can implement in our clinical practice the message that we had obtained from all these academic bodies. Lower the better, as far as the blood pressure lowering is concerned. Faster the better. If you are able to bring down the blood pressure to the goal within 6 months, within 3 months, better. Better quality of BP control, we need to aim for that. Initiate always with the 2 drugs, of course, in a single pill combination, and try to avoid giving single drug. It may be chosen for very elderly above the age of 80 years, frailer individuals, or people with a concomitant disease and not able to tolerate due to so many other problems. Please remember that you need to follow an evidence-based simplified treatment algorithm. Very, very important. Having listened to these guidelines, if the guidelines that are not followed, I feel they are of no value. My last slide, which is a cartoon, the patient with hypertension urges the doctor to punish him or push him for tablets. Now, this is actually a very bad approach either by the patient as well as by the doctor. And he is not actually adopting the best method of examining the patient for blood pressure. He is doing a wrong method. He is punishing the fellow with some tablets. And the fellow who is standing outside this chamber is an obese fellow with problems, some probably metabolic syndrome or obesity. He is an alcoholic, he is a smoker. So we need to consider all associated risk factors which are seen in hypertension. And if we are able to concentrate on all these risk factors, it is possible to reduce the cardiovascular events. So hypertension should not be treated in isolation. You need to concentrate in all other risk factors which are seen commonly in association with hypertension to reduce the cardiovascular burden, including the mortality. Thank you very much, ladies and gentlemen, for patient listening.
Thank you, Dr. Narasimhan, for a very lucid and an excellent talk. I think the 3 messages that come out very clearly from its talk are, number 1, no matter what the various guidelines that have come from the different continents, whether it be the American College of Cardiology or the European or even the International Society of Hypertension, they may differ in the threshold of hypertension and the classification of hypertension, but please remember that the goal remains the same, that is getting a blood pressure down to less than 130/80. Number 2, his message that comes out very clearly from his talk is that it doesn't matter which drug you use as long as you attain a blood pressure of less than 130/80. And number 3, in usually places where there is resource limited, it is better to use combination therapy to improve adherence. I think, Dr. Narasimhan, these were the 3 major messages you want to give to the primary care physicians. Thank you very much. Now, if there are any questions, I'll hand over to Professor Anuj Maestri for moderating the session further.
Thank you. Thank you, Dr. Vermani. Very nicely conducted and summarized the session. And very nicely you sent a message to the audience. All the 3 speakers has done the justice with their topic, and they have spoken very nice deliberation. And Dr. John Flack and Dr. Narsingh Verma is very much active on the chat, and he is answering many of our questions. So most of the queries are already well answered, but there are certain queries which are coming from the attendees. I am taking them and has not been taken on this platform. So one is very important thing to Dr. John Flack. I would like to ask Dr. John, do you find in your elderly patients some inconvenience with the diuretic? Because many of my attendee doctors are finding very inconvenience while using in elderly and old patient, especially when comes to the diuretics.
Yeah. So, some elderly patients are sensitive to diuretics, and our approach around that is the following. One, really try to get them to cut their sodium intake to a degree, because the diuretics will cause urinary urgency as they're kicking out sodium. So the more sodium you take in, the more you're going to urinate. Two, we favor in those patients indapamide as opposed to chlorthalidone, because indapamide, even though it's very effective and as a diuretic, does not cause as much urgency as chlorthalidone does. Three, you can get urgency in urination when your blood pressure is high. And so some of the urination is probably high blood pressure, and in nocturia at night is either high blood pressure at times and or untreated, inadequately treated sleep apnea. And finally, remember that when you have chronic kidney disease, one of the first things you lose your ability to do is concentrate your urine. So patients with chronic kidney disease will also end up urinating more. But if you don't want to use indapamide, try initially the CCB, ACE inhibitor, or preferably ARB combination, and that'd be a great place to start. That's another way to sort of try to avoid the diuretics, at least through the first two drugs.
Thank you, Dr. John. Dr. Narsingh Verma, the next question is for you. The people wants to know that in adolescent hypertension, should we give more time for the lifestyle modification? Because in most of the time when we come across with the youngsters hypertension, they are not really ready to start the treatment in the pharmacological way, and they prefer to go for a longer time with the lifestyle modification, whether it is successful or not. We don't have any clear-cut guidelines regarding that, when to initiate the treatment. Should we rule out all the causes of the secondary hypertension and then we should go for the initiation of the treatment, or we should start targeting the correction of the blood pressure since the very beginning when we find him hypertensive? What is your take on this?
Very good question, I will say. And in my presentation, I pointed out that if the secondary hypertension is there, then we need not to wait. We have to start the drug and also treating the primary cause, the cause responsible for it. But in primary hypertension, in the pediatric age group, most of the guidelines of the world, they advocate that at least we should give 6 months before we go for the drugs. We can wait, but it depends upon whether at the time of diagnosis, if the adolescents are already having the signs of target organ damage, then the needless to wait, we have to start lowering up blood pressure, by which means we can achieve it. So it will depend upon workout of the patient. If the subject or the patient is having the diagnosis as hypertension adolescent age group and showing no signs of any target organ damage, then we obviously should wait for the lifestyle intervention. And one more thing has been seen by the various guidelines, and various researchers have found that anyhow, the lifestyle intervention has more role in the adolescent hypertension rather than in adulthood. So it works better in adolescent age group. We should go for an extensive lifestyle modification first, then come to the drug.
Right, sir. Thank you. Now, another question to Dr. Narsinghan. Dr. Sanjeevi Narsinghan, very nicely deliberated talk by you, and we have really got much of the clarity over the guidelines. Dr. Narsinghan, who is also the president of the Indian Society of Hypertension, would like to ask from him that now is the time that many people tell about their blood pressure on online consultation. They do the home blood pressure monitoring, and they inform the doctor about their blood pressure readings. How much it is beneficial to go with that while making the changes in the treatment of the hypertension, or can we initiate the treatment of the hypertension on the basis of these reading? As you very rightly shown in your last slide, many of the times, many things are not well noticed by a doctor when he is doing the distant treatment. So it's over to you for the answer.
I think it's a good question. Now that we are witnessing this pandemic and it is going for beyond the expected time also, we need to probably go into this sort of management of patients who are actually consulting you from a remote area through digital platform. In case they are bringing the home blood pressure monitoring, if they had been well trained in evaluating the blood pressure at home, either by the patient or by the relatives, if the valid readings had been shown to you earlier also on occasions when you had physical meetings with them, if you had a good belief in their recording, and if you know that they had been doing it in a sincere way, there is always a justification to increase the dose or escalate the dose, depending on the measurement what these people are now coming out, number one. Number two, in case you don't have idea about their measurement of blood pressure, whether they are strictly following the methods what you have taught to them or what you are teaching them. In case there is always a doubt, probably you can wait for next 1 week or 10 days, again ask them to produce the results. So you can take an average of these readings and see whether it is on the higher side. If there are no symptoms and if it is going to be on the rise, then if all other parameters, if you are making a video call, you can always look at the patient's general condition, you look at pedal edema, look for JVP rise, there's no symptom like heart failure, there's no cardiac problem, there's no renal problem on clinical grounds. And if all other parameters in the laboratory are also normal, I think you can modify the dose. There should not be any inhibition by just avoiding the patient to have the same old dose. No, you continue to take the same dose. You always try to escalate the dose depending on the response.
Thank you, sir. Now come back to Dr. John Flack. Dr. John, there are a few questions coming from audience attendees, and now this is the COVID times and they are very much interested to know about the relation of the COVID-19 with the hypertension and how should we really treat hypertension, especially the newly detected hypertension in this COVID times, or if the patient who is already taking antihypertensive and getting deteriorated, how should we go with that?
Well, what we did when the COVID was really spiking here is we went mostly to telehealth. And one advantage we have with telehealth is our patients get trained on how to measure their blood pressure. So we have an understanding that they at least have been instructed on how to accurately measure their blood pressure and typically have shown us that they can do it. I think it's hard to know exactly what to do. Some of the associations with hypertension are probably not causal with COVID and worse outcomes, but probably related to the factors that are linked to hypertension, like obesity, for example. One of the big complications of COVID really is like a cytokine storm, inflammation. And obese people definitely have more propensity for that. So we haven't grossly changed our treatment, except we have done more out of office treatment than before, which in my view is not as good as in-office treatment, but is better typically than nothing.
Thank you. Dr. Narsingh Verma, now this question is for you. How much the importance of serum homocysteine is there in diagnosis or in treatment of the hypertension when we really look forward the risk factors?
Homocysteine levels are catching up nowadays, and mostly because today one trend has come in nowadays, that is more and more investigations. And lot of pathology people and others are talking about homocysteine levels. They may be important, but initially when the guidelines have been made, the homocysteine level alone or in isolation do not have any meaning. If the other investigations are not within normal limit and homocysteine levels are also done, then they can guide us. But I don't think that individually homocysteine levels must be given much importance. A lot of investigations today and these days are there, and our own clinical judgment is being affected by these investigations. So we have to take it a little with a bit of salt that the homocysteine level alone may not be that important. But of course, if other target organ damage and other things are there and homocysteine levels are high, then definitely we must keep this in our mind.
Thank you. Dr. Narsingan, there is a question for you that many guidelines now have started recommending to initiate with dual drug if the patient is in the second stage of the hypertension or more than that. How should we do the escalation of the doses? Suppose we have started one dual drug therapy and patient has reached to the normotensive and now he has started coming to the normal level for a longer time. Is there any scope to withdraw one of those drugs, or we should continue with the both drugs till it is not required to increase?
Having seen these three guidelines which I projected, the International Society of Hypertension tells you that you should start a single pill with a combination of drugs, starting with the lower dose of each drug in a single pill. The next step will be, depending on the blood pressure response, go for an increase in the same drug, dual combination with a single pill with a good amount of dose. In case the patient is not responding, then go for the third drug. In case the patient has shown a good response with the drug that you have started, either with a small dose or with the highest dose of a combination of drugs, probably you can de-escalate the dose depending on the blood pressure what you are going to see. In case the systolic blood pressure goes down less than 120, I think there is always a justification depending on the age, concomitant factors, coronary artery disease, CKD or diabetes. We should be very careful. Bringing down the blood pressure less than 120 is not good for a patient with diabetes. So you should be very careful because the ACCORD study did not show any sort of improvement. If you bring down the blood pressure by less than 120, there is more events. The cardiovascular events are much more in the ACCORD study, where they've included people with diabetes. Less than 120 again is not valid at all for elderly people. So you should be very well equipped with all this information before you start reducing the dosage of these drugs. So if the blood pressure response is actually coming down, and if you are satisfied that the patient is not having concomitant factors, and if he's not symptomatic, he's not having orthostatic hypotension, he doesn't have any sort of complicated aspect of the medications what you have started, including the electrolytes, probably you can continue to give him the same drug, or slowly you can reduce the dosage, but try to keep the same dual combination. If you had given a dual combination of highest dose, bring him down to the dual combination with a smaller dose. That's the way in which probably you can manage. Ultimately, it is the decision that is made by you and the patient for a continuous, uninterrupted treatment for this.
Okay, thank you. Dr. John Flack, this is question for you. In India, many people presents with left ventricular hypertrophy when they are first diagnosed with the hypertension. And what should be the preferred choice of the drug in such patient, those who are having left ventricular hypertrophy, as well as is there any drug which can help us in reducing the left ventricular mass reduction?
So when I first got into hypertension back in the 1980s, there was a lot of talk about what drugs did and did not reverse left ventricular hypertrophy. Virtually all the drugs probably will if you control the blood pressure. It's not just going to be a single drug. You're going to need multiple drugs. And then within that, it's like, well, are there drugs that may be more effective in reversing remodeling? Well, people with LVH, diastolic dysfunction, we like verapamil, for example, in part because it allows the ventricle to relax better. There are drugs like aldosterone antagonists, ACE inhibitors, ARBs, which will help with ventricular remodeling. The ARBs are very, the aldo antagonists are very good at that. So we strive to put together a really effective drug regimen that will lower blood pressure effectively, and try to include some of those drugs, and almost surely we will, like ACE inhibitors, ARBs, calcium blockers, aldo antagonists. And I think that's the best that you can do. And if you actually, in patients who can afford it, if you have even diastolic heart failure with preserved ejection fraction, and your ejection fraction is probably not much above 50, the neprilysin inhibitor and valsartan drug, trade named Entresto, sacubitril, valsartan, actually has good outcomes data, even in people whose ejection fraction is not preserved. But that is an expensive drug, and I run into problems here in the States getting people to be able to afford it.
Thank you. Dr. Narsingh Verma, what is the best treatment for hypertension in adolescent age group if it is coming to the obese child? So what will you suggest for him?
In obese child, the best treatment will be the reduction of weight. So lifestyle intervention definitely will play a major role. But if even after applying all this, the blood pressure is not controlled, then we have to go for the drug. And whatever recommendations have been made, they say that probably the ARBs or ACE inhibitors will be the drug of choice initially. And they can very well take care of the hypertension in the obese people. But definitely weight reduction by any means will be more effective, and the drugs becomes next to that.
Till the person is reducing weight, should we keep him on antihypertensive medication?
Again, I will say that that depends upon the other investigations. If the target organ damage has started, albuminuria is there, and other signs are there, then definitely we have to use drugs. No harm in using them. But our emphasis should be more on the lifestyle intervention, but they should be combined with the drug if the patient is having impending the target organ damage.
What is your opinion about India? Adolescent hypertension is more for the secondary hypertension or because of the primary?
That's what I was saying. In my own study, which we are conducting, still the data is not very high. The COVID would have not come. We have crossed 20,000 data. In the coming time, definitely we will do that. That has shown that secondary hypertension is not that common in our Indian adolescents. It is the primary one which is taking up. And basically, even the obesity and overweight is not that common. Even in those children who are not obese and not having overweight, is still the hypertension is there. Probably the most common cause which we were able to ascertain is the stress level. They are subjected to a lot of stress, and because in their college, their schools, a lot of competition is there, and stress level starts from even in the Montessori classes, even KG nursery classes. Maybe that is causing harm to our children, and they are becoming hypertensive.
Thank you, sir. Probably we are completing to our timeline. So this may be the last question to Dr. Narsinghan. Dr. Narsinghan, there are the two things which I want to clarify from you. That one is that for the elderly patient, as you have very rightly indicated in your last answer, that elderly patient should not go less than 120. But at the same time, you in your presentation, you said that cutoff for the diagnosis of hypertension as well as for the target should be less than, should be 130 mm of mercury, even in the patient, those who are of more than 65 years of the age. So won't you find this is very narrow range of maintaining hypertension? Would it be really practical and possible for the peripheral practitioners or clinicians to do this in short range of the blood pressure, especially the systolic blood pressure?
I have shown you one important trial, that is a accomplished trial, where people had seen the reduction of blood pressure from 140 to 130, the events are more. From 130 to 120, the events are coming down. Whereas from 120, it is going up. You should not probably aim for a reduction of blood pressure less than 120. So you should try to keep it around 130 all the time. Less than 130, does it mean 124, 122? We don't know exactly. All that you should do is to probably, according to the patient's criteria, whether he has got a comorbid condition, what is his age, whether he is suffering from some other problems. You need to take all those into account, and based on the blood pressure, what is now being measured by you after the treatment, you need to probably titrate the dosage of the drug and make him comfortable with the reduction of blood pressure levels. For example, if he is coming down to 128, doesn't matter, he can always allow him to do that. 135. Whereas when he is reaching 122 or 120, probably is going into the next area where probably you may not get that benefit. So you should always try to tell him that the blood pressure need not be reduced to that level. We need to keep it at that higher level. Try to take good amount of medications, whatever we have prescribed, and don't exceed the dosage. Come back and report. Try to do the lifestyle modification. We'll withdraw the drugs as and when it is really required. You measure the blood pressure again when he comes back. Try to reduce the dose of the drugs what you've already started. That is the best way of managing elderly people above the age of 65 when you are seeing these patients when the blood pressure is going very near 120.
Thank you. One thing I would like to emphasize is from your presentation that for people more than 65 years of age, cutoff is of the systolic blood pressure is the important. We should not take diastolic blood pressure much for the consideration of cutoff as well as for the target. What is your take on that?
Diastolic blood pressure is also very important. If you are able to bring down the diastolic blood pressure around 80 is fine. But when you are going down below 80, and if you are going down below 70, that means it is going to be injurious, because the diastolic filling occurs for the coronaries only during diastolic period. So coronaries get filled only during diastolic period. If you are bringing down the diastolic blood pressure less than 70, none of the trials have shown reduction of blood pressure diastolic below 70 had helped these patients. So diastolic blood pressure is also very important. Right to keep it at the level of 80. I always tell my people also, if you like to live for a period, if you like to have good parameters, you try to keep LDL levels of cholesterol 80 milligrams and the diastolic blood pressure 80. You try to keep 80 meters away from the smokers, and you try to walk for a period of 80 minutes, 3 days a week, and again 3 days a week. And then your heart rate should be, or the pulse rate should be less than 80. So try to keep all these 80, then you live for 80 years.
Oh, thank you. Very nice message. But there is one problem which the people facing, that when they try to reduce the systolic hypertension, once the diastolic blood pressure is normal, almost 70 or 80, and we try to reduce the blood pressure, sometimes it happens that diastolic blood pressure goes up to the 50, 60. What is your message to such situation?
I think the dosage of the drugs need to be tailored in such a way that you don't use too much of diuretics and such things. Combination of drugs, you should be very careful in using it, particularly when the diastolic pressure comes down. So try to give the maximum of one drug and then the minimal dose of the other drug, and try to titrate like this, and then go for a good control of systolic blood pressure. The isolated systolic blood pressure is actually very difficult to control. You require a combination of drugs, but you need to choose calcium channel blocker as the first drug, maybe with a diuretic. The diuretic dosage need to be adjusted accordingly, particularly with respect to the diastolic blood pressure. And it is possible to reduce the systolic blood pressure without harming the patient by reducing the diastolic blood pressure. It is possible.
Okay, thank you. But most of the times the people find it. So your message is that people should be happy with little higher systolic blood pressure, but they should not try to reduce it if they find that diastolic blood pressure is going below 70 mm of mercury.
It all depends on the stage at which you see the patient. For example, 180 systolic and diastolic is about 70. At that stage, you are seeing the patient 180 by 70, and there is no aortic regurgitation and all. You have ruled out all sorts of hyperdynamic circulatory state. Fellow is designated as a case of the isolated systolic hypertension. You try to manage this patient in such a way that you institute a calcium channel blocker to the maximum dose. and then add a diuretic also. Depending on the age, you try to adjust the dosage of this drug. Many patients will bring down the systolic blood pressure. Such patients need to be submitted for an ambulatory blood pressure monitoring, which will tell us whether there is any target organ damage. If the target organ damage is established by ambulatory blood pressure monitoring, and if the blood pressure is high during nighttime and early morning surge, that means you need to probably try to aggressively treat these individuals, keeping in mind that the low diastolic pressure may not be very significant, whereas the reduction of systolic pressure is much more important.
Okay, thank you. Dr. John Flack, there is one question coming for you that in COVID times, we are getting many patients having high blood pressure because of the steroid therapy they are using in COVID times. So how should their hypertension be treated? Those who were not hypertensive before getting COVID, but once they used steroid, then they got hypertension. How should we deal such patient?
That's an interesting question. Here's the way I'd approach it. I don't see much of that, but I think if they're going to be on steroids for an extended period of time, you might worry about treating it. If they're going to be on steroids for a short period of time, say under 4 to 6 weeks, I probably would not treat it. I would just basically try to get them to minimize their sodium intake and ride it out. I don't think I'd start therapy under that circumstance. The real issue from blood pressure is really long-term. And so for somebody who's not hypertensive and develops a short-term blood pressure elevation, their risk is not going to be great unless it goes severe. So I wouldn't treat if they were going to be on steroids under 6 weeks or so.
Thank you. Thank you, Dr. John. And now we have completed almost the timeline, and in fact, we have crossed our timeline about 10 minutes. So I would like to finish this session here only with a precious thanks to Dr. John M. Flack, who joined from USA and given good time. He stayed with us at least more than 2 hours, and we really enjoyed his company as well as his intellect. He answered the question in our chat box to each and every person. I really appreciate the interest and services of Dr. John M. Flack, which he has given for the American College of the Physician India chapter, as well as Indian Society of Hypertension. So we are thankful from both the organizations. Dr. Narsingh Verma, who has taken up this job at very short notice. We are really thankful for giving the wonderful lecture, a nice enlightening lecture. Dr. Narsinghan, as always, has been the greatest speaker, and he is very much preferred speaker across the country as well as out of the country. So he is always good with his deliberation. So as usual, he has done the wonderful deliberation with all these 3 speakers. Thank you very much from all of us. It was the beginning of the May measurement month because Hypertension Day is in the 17th of May. And this year, we may not be having much of the programs because of the COVID times. Most of the places of the India are in the lockdown or in the curfew. So probably the gatherings won't be possible. We are delaying the May measurement program also for the same reason which we do with the International Society of Hypertension and Indian Society of Hypertension. American College of the Physician found a nice opportunity to begin with hypertension topic so that we can take this and use this opportunity of the hypertension month to educate more and more doctors as well as others, healthcare workers about the hypertension. With these words, thank you all advisory council members of the ACP as well as Indian Society of Hypertension being with us, being with me, being with ACP. Thank you very much.
Thank you. Thank you.
Thank you. Thank you.
Thank you.
Good night. Good night, everyone. Stay safe.
Good night.
Good night.
Bye-bye.
Sheetal or
Good
Vikas?
night. Anuj, congratulations. Fantastic program.
Thank you.
First
Thank
program
you.
of ACP.
Thank you,
Great.
Dr. Bansi. You joined. It has been a great pleasure for all of us.
We were always there, Whenever Anuj call us, we have to be there, by all
Thank you.
means.
So nice of you. So nice of
Great
you.
program, sir. Really. Thank you, sir.
Anuj, now it is your first program, Now we are waiting for your dinner.
We are waiting for
dinner, you know. We all
Yeah,
are
yeah,
waiting
of
for
course.
dinner.